Filariasis, a very interesting topic, and I think the picture itself is representative of what we are going to see in this particular lecture. So, without wasting time, let's go in. So, first of all, what are these? These are slender thread-like worms belonging to the nematodes family. They are transmitted by mosquitoes or blood-sucking insects. It can have adults and embryo phase, which is called as microfilaria, which both can be seen in human beings. And these microfilaria will retain their egg membrane, so they are called as sheathed microfilaria. The vector-borne parasites, obviously, the mosquitoes play an important role. They can cause infection in the lymphatic system, skin, subcutaneous tissue, and very rarely body cavities. So what do you have? We have three different types. You have the ones which are affecting the lymphatics, which is Wuchereria Bancrofti, Brugia malai, and Brugia timuri. Subcutaneous tissue, you have the lower, Onchocerca volvulus, Manzanella streptocerca. Serous cavities, you have the Manzanella ozardi and Manzanella perstans. Today we'll talk more about the ones which affect the lymphatic system. So this is just for reference to know what exact disease we are talking about, only for educational purposes. So these worms, you have the adult form, which are quite slender and measuring around 2 to 10 centimeter in length and will survive for many years inside the lymphatic system. So they can cause chronic obstructive and inflammatory conditions like elephantiasis and hydrocele. Larval forms, you have 4 stages. The first and foremost is the microfilaria, which is virtually non-pathogenic but can cause some symptoms. As they molt around, they have the third stage larva, which is the infective to man, which is called as a filariform larva. And this microfilaria, which are basically non-pathogenic, can cause some hypersensitivity reactions, because anyway these are foreign bodies inside our body, so they can cause some hypersensitivity reactions, which will lead to tropical pulmonary eosinophilia. There's something called as a microfilarial periodicity, means these microfilaria will be active at the time when the vector will come and feed on the human beings, so that they can transmit into the blood, go into the mosquito, and continue their life cycle. Apart from that, you have the sleeping pattern of the individual, temperature, body temperature, and other climatic conditions, which can also vary depending on the interaction between the microfilaria as well as the mosquito. Vectors, most commonly is the Culex mosquito, which is importantly responsible for causing or spreading this infection. So you have this Bancrofti, which is a widely distributed filarial parasite. Around 90% of cases of lymphatic filariasis are because of this Wuchereria Bancrofti. It is named after two scientists, Wucherer, Otto Wucherer, and Joseph Bancroft. And this thing completes its life cycle in two hosts. One where the man is a definitive host because the sexual cycle happens in the man, and mosquito being the intermediate host where the asexual cycle happens. Let us quickly look at the life cycle in the mosquito. So the mosquito bites, the microfilaria via the blood reach the stomach of the mosquito. They can slowly remove their sheath in 2 to 6 hours, and they can penetrate the stomach wall of the mosquito. Once they penetrate, they take around 4 to 17 hours to slowly move towards the thoracic muscles, where they will slowly metamorphose over the next 2 days to form the first stage larva, which is like a sausage shaped with a pointed spiky tail. In another 1 week's time, these larvae increase in size, leading to the second stage larva, and then they become the third stage infective larva, which is has a defined internal structures, motile and disinfective. Now, once they gain their infectivity, they will enter the proboscis of the mosquito, so that they can easily transmit to human beings when the mosquito bites the human beings. So this is called as an extrinsic incubation period, because the whole cycle happens outside the human body. So what happens inside the human body is when these mosquitoes, the infected mosquito, comes and bites on the human being, the larva is deposited in pairs, and via the puncture site or these the filarial worms can puncture the skin themselves. They will enter the lymphatics. From there, they will go into the abdominal or inguinal lymph nodes. Throughout this journey, many of them are killed, so you need a very high infective load for the patient to develop infection. From those lymph nodes, they will stay there and they will slowly become into adults, and by around 6 months' time, they will have the sexual maturity. So there, what happens, you have these gravid females releasing around 50,000 microfilaria per day, and which can pass through the thoracic duct, pulmonary capillaries, and enter the peripheral circulation and finally cause the clinical symptoms. Two important terminologies you need to remember here is biological incubation period. That is from the time period when there is a bite of the mosquito to the time when the first parasite is seen in the peripheral circulation is a biological incubation period. This is different from clinical incubation period. So what is it? That is from the bite of the mosquito to the first clinical symptom is a clinical incubation period. So what happens when these worms are there? So these live worms will migrate. So they can cause lymphatic dilatation and thickening of vessel walls. Once the worms are dead, they can release antigen and toxic metabolites. So that will increase the granulation fibrosis of the lymphatics. They can be secondary bacterial and fungal infection depending on the area where this granulation is happening. There can be an inflammatory reaction because of both live and dead worms. So this will attract the eosinophils, macrophages, and plasma cells towards the lymphatics. So the lymphatics become more tortuous, damage the vessel valves, and there can be lymphedema of the limbs because once the valves are damaged, the lymph cannot flow very easily back into the circulation. So what does our body do during this time? Both the humoral and ciliary immunity are affected. So first of all, the adult and microfilaria antigen will be processed by the macrophages. They will be shown to the T cells. T cells will differentiate into T helper cells 1 and 2. And in early infection, both the cells are pretty much active. As the disease progresses, what happens? The T helper 1 cell response comes down. So the Th2 response will be there. So what will be the effect? There will be increased levels of interleukin 4, 5, 10 and 13. There will be increase in amount of eosinophils. There will be increase in amount of IgE and marked increase in number of the molecules of IgG4. As the infection becomes chronic, there will be increase in IL4, IL5 and IL13, and instead of IgG4, IgG1 and 1, 2 and 3 will predominate. So acute filariasis, what happens? You have the filarial fever. Next, you have the lymphatic inflammation, that is the lymph vessels, and there will be swelling of the lymph nodes, and more commonly in the lower extremities, and sometimes it can also happen in the upper limbs as well. Then there will be a local edema, which is early petting type, can be reversed on limb elevation. It happens only in the acute phase. Then you have what is called as a dermatolymphangitis, which is like a plaque-like lesions formed over the affected skin with fever, chills, and lymphatic inflammation. In chronic condition, what happens? There's a granuloma formation, which leads to fibrosis of lymph vessels, severe lymphatic obstruction, and fatal edema. So, result of that, what will happen? There can be elephantiasis, hydrocele, chronic funiculitis, epidermitis, and chyluria. So, if you notice, most of the symptoms are there in the areas which are dependent on gravity. So what are these things? So elephantiasis, swelling of the lower limb, which is more common. At the same time, arm, vulva or breast can be affected. Hydrocele is next most common manifestation, where there's accumulation of clear straw color fluid in the cavity of tunica vaginalis. There can be chronic funiculitis and epidermitis. And chyluria is when a milky white fluid is seen in urine, that is due to rupture of lymph vessels into the urinary system. Then we come to the terminology of tropical pulmonary eosinophilia. It's also called as occult filariasis. So here what happens? All the microfilaria are cleared from the bloodstream. They filter and lodge in the lungs and initiate an allergic response from there. So when you take the blood sample, you might not see any microfilaria, but the allergic response is what is responsible for this particular condition. There are other types of filarial infection. One is what is called as an endemic normal. That is in endemic areas, because the people have enough amount of immunological resistance or the exposure is not enough, there won't be any kind of signs or symptoms. Then you have the asymptomatic microfilaria. When in endemic areas, people are infected, but they do not exhibit any symptoms of filarial infection. But if you take a blood sample and see, there might be microfilaria, and you can also see some lymphatics which have been enlarged. Lab diagnosis, the basic idea is to look at the microfilaria. This video I took from the YouTube just for educational purposes, just to show you the microfilaria in the blood. So that is for demonstrating the serpentine movement. Plus, you can have a thick smear and thin smear which can be done to perform the so that the microfilaria become visible. These microfilaria can range anywhere from 1 to even 10,000 in number per ml of blood. So here, if you notice the main difference, there will be a lot of points which we need to know about the differentiation. But for undergraduate students, the main two things we have to see: the head space, you have no nuclei, and the tail space, you have no nuclei. That is Wuchereria Bancrofti. If I have a little bit of nuclei in the head space and some one or two nuclei in the tail tip, it is a Brugia malai. Then you have the diagnosis part, where the concentration techniques. So first of all, it's a membrane filtration technique and knott centrifugation, where you use formalin to kill the RBC and you can filter out the centrifuge and take the microfilaria separately. The most important thing in diagnosis of microfilaria or filarial condition is when you take the blood. Ideally, if you can take the blood between 9 p.m. to 4 a.m., you'll be able to identify microfilaria very easily. If it is not possible, then the ideal thing is to do a DEC provocation test, where you give the patient DEC tablet calculated as 2 mg per kg body weight, so that the microfilaria will be stimulated and they will come into the peripheral blood within 1 hour's time, and will be able to diagnose this microfilaria even in the morning time. Then you can do a quantitative Buffy coat method, where blood is centrifuged, stained with fluorescent dyes, and seen under fluorescent microscopy. This is more sensitive than your normal smear microscopy. There can be false negatives. What are the reasons? It can be occult filariasis, chronic filariasis with endemic normal people, and wrong time of blood collection. As usual, for any other parasite, you have the antigen detection, which can be against using monoclonal antibodies against the antigens like AD12 and OG4C3. And what your methods you are going to use is ELISA or immunochromatographic methods. The more sensitive, I can do during the daytime also. It can differentiate from the past infection, and it is not very useful in detecting Brugia infection. Antibodies, mostly it's used for epidemiological purposes, because you will not be able to differentiate whether it's a fresh infection or an old infection. For that, you can use a flow-through assay or luciferase immunoprecipitation system as well you can use. Imaging is pretty much helpful. So here you have the ultrasound, which shows the serpentine movement, and this is called as a filarial dance sign. You can also look at the X-rays, where some of the worms can be dead and calcified, which will be visible on X-rays, or you can do a lymphoscintigraphy of the limbs, which will demonstrate the functional abnormalities of the lymphatics. If facilities permit, we can do a molecular methods like PCR, real-time PCR, so that you will be able to diagnose even with a very less amount of parasites. You can differentiate between the past and present infection, and once your treatment has started, it will be useful to monitor the treatment response, and you can distinguish between the filarial parasites. Apart from that, you have some other tests like eosinophilia, elevated levels of IgE, biopsy of the enlarged lymph node, and urine examination. So what do you treat? You have the main choice of treatment is diethylcarbamazine. It's given at 6 mg per kg body weight for 12 days, so it can kill both the adult worms as well as the microfilaria. Albendazole is given as 400 mg twice daily for 21 days, and it is quite effective against adult worms as well as microfilaria. You have the ivermectin, which can kill microfilaria but has no effect on adult worms, and in areas where there's a high rate of filariasis, it's not very useful. So the prevention part comes in. So first of all, the backbone of prevention is the vector control, and the program by National Vector-Borne Disease Control, which is based on the project on elimination of filariasis. So first, you have the anti-larval and anti-adult measures, where you can use the pyrethrum sprays, which can be which can kill the larva as well as the adult mosquitoes. Then you have the elimination of lymphatic filariasis, which is a global program. So in India, it is taken up by the National Vector-Borne Disease Control Program, which is against 6 vector-borne diseases, where what is the base idea is to give a mass drug administration once in a year for 5 years to the at-risk population. So here what you use a combination of DEC albendazole. So this can be used even for onchocerciasis and loa. There's a separate WHO strategy where the regimen is ivermectin, DEC, and albendazole. Some of the districts in India have implemented this. The additional advantage of the program is they can also look for the effect using a mass drug administration. That is why microfilarial survey by peripheral blood smears and transmission assessment survey by using antigen or antibody detection. Next, you have the Brugian filariasis, where around 10% are because of this particular Brugia malai, which is seen in mostly in eastern India and Kerala. Life cycle is somewhat similar, except that the vector of this particular parasite is Mansonia and lesser by Anopheles and Aedes. The condition is somewhat similar. Most frequently, it causes acute adenolymphangitis and filarial abscess. Chronic manifestations are less. The genital involvement is not seen. Elephantiasis, the swelling is in the lower limb below the knee and not much in other places. Chyluria does not occur in Brugian filariasis. So, how do you detect? So, obviously, we have seen the differences in the cephalic and the tail tip. Then, apart from that, you have the antibody detection method using immunochromatography and ELISA. Brugia Rapid is a test which can be used for a parasite-specific IgG4 antibodies, as well as you can use a Brugian malai antigen, which can also be used for detection of microfilaria. How do you treat? It's the same as your Bancrofti and filariasis. And one additional point is you can remove the pistia plants, which are a very good area where the mosquitoes will multiply. So the vector control happens naturally. Finally, you have the Brugia timori, which is basically also a cause of lymphatic filariasis, most commonly seen in the Timor Islands and the Indonesian area. That's transmitted by Anopheles barbistrois, and the clinical features, lab diagnosis, treatment, everything is somewhat similar. So finally, to conclude, just let's sum up with one infographic where you have the parasite, you have the nematode family parasite, which affects the subcutaneous tissue and lymph nodes. You have different stages. You have the adults, you have the microfilaria, you have the filariform larva, which spread in between the man and mosquito and cause the disease. So what does it cause? It causes lymphatic dilatation, fibrosis, and lymphatic obstruction. Clinically, you can diagnose using a microscope, using blood smear, concentration techniques. What are the clinical things? You have elephantiasis, hydrocele, which can be very prominently seen in your patients. Treatment-wise, DEC, ivermectin, albendazole can be used, and prevention is by mass drug administration. I hope this video was short and sweet and easy to understand. Please do let me know if there's any other topic which you'd like to see in this particular channel. Kindly like and share this video to your friends and subscribe to my channel. Thank you.